We now will have a moderated discussion. This is my first hybrid moderated discussion. We'll see. I'd like to start by asking Betty and Eric to reflect on Lisa's story and to take it from the frame of your work. Betty, you can take it from the recommendations or anything you want, but I'd like each of you to reflect on Lisa's story for the benefit of our audience today. And so I'll give you a minute to think about that. And go ahead, Betty, when you're ready.
You know, the first thought that comes into my mind, and thank you so much, Lisa, for sharing, but as you were speaking, the first thought that came into my mind is, and this is the story of a highly educated family caregiver who is articulate, speaks English, and has resources available to her. And if this is her story, you know, what is the story of all the family caregivers who do not speak English, are not highly educated, are not well prepared in Alzheimer's care, and probably worse yet, and what is the experience of those patients who don't have a family caregiver there advocating for them? And so I think, you know, one of the key messages of our report from our committee is that, you know, quality patient care has to really start by identifying, you know, who are the people that we're talking about and their real quality of life concerns, and that we can't build a system, you know, that cares for only those with the greatest resources, but how valuable it is. Lisa, you know, I can tell you in my 40 years of experience of thinking about quality, we can do all the literature reviews imaginable, but it's when we hear the real stories of real patients and families that we are reminded of the work that needs to be done. So thank you so much for sharing your experience.
Thanks, Betty. And I'm going to turn it over to Eric.
Yeah, thanks, Terry. Lisa, your story is just, I could share several similar other, had we enough time, we could probably identify many of the sort of tribulations that occur. And the point about this being a challenge even for people in the best of circumstances with staff who are dedicated and compassionate in the jobs that they're doing, yet can't connect the dots across the systems, whether it's EMS, the emergency triage, the hospital system, just getting basic information like the MOLST where it needs to be and having people respect that information. Those are the challenges I see that I think I was trying to articulate around the system and the ecosystem, and trying to figure out how to re-engineer the ecosystem, whether that's through health plans or accountable care or some other set of mechanisms to try to knit together the fragmented system. I was also heartened that the MyChart app alerted you to what was actually going on. And to me, that illustrates the potential of the technologies to flag these situations, to flag the thing that's happening that just as I don't know how many times others have had their credit cards shut off because you made a purchase in the wrong place at the wrong time, but the credit card companies are quite good at monitoring and identifying irregular patterns. In clearing my mother's house, the other thing I discovered is that there were signals all over her apartment that things had been going south for 8 months or 9 months before we identified the problem. And there were probably signals in the digital world that would have flagged that as well. And so I think there's some inspiration actually in the fact that the COVID-19 test result flagged you. There are probably other ways we could use that kind of informing technology to trigger alerts when things are happening that shouldn't happen, like NPO for 3 days. That shouldn't even be possible, right? That should be engineered as a as a red flag.
Mm-hmm. Thanks, Eric. And in a minute, we'll have additional questions from the audience. I'll make 3 points, if I may. We're telling stories, powerful stories. We need to get our stories to different audiences. And the example I'm using is in my own experiences. Our foundation works with WebMD and we work with NBC News. We pay them shamelessly to help us tell the public, because the public needs to have voice and knowledge of what we're talking about. My friend Tracy Lustig here at the Academy always says that we cannot continue to sit around admiring the problem, and that action orientation is critical to what we need to do next, and that identifying, there are many banks have programs for older people who might be concerned about their capacity to manage, and we all need to make sure that we're aware of and that we tell our patients about that. And the last comment I'll make before going to the audience and asking Bruce Vladeck to make a comment is that as a nurse who gets called a lot, as I'm sure all of the clinicians in the room do, I say to families, can you imagine a day when you would not call 911? That makes it very concrete for people. And it's all theoretical, and then until you say, if I stop breathing, can you imagine a time when you'll not call 911? We have taught the public to do that. That's what they do. We have a system that's, as they say, perfectly set up to give us the results that we've set up. So begin to use very concrete examples with people and think about how to get beyond usual audiences. I know all of us are thinking about that last point. We have funded frameworks here in Washington, D.C., and they have a powerful report called Reframing Nursing Homes, and it's how to talk about the National Academies report and how you have to be solution-based, because otherwise people's eyes glaze over and they say, there's nothing we can do, it's too hard. It's not too hard. So Bruce, whenever you're ready to take the mic, as somebody who is on the original nursing home report, we want to hear your 2 or 3 comments today, and I know you will do that for me. Here he comes. And I'm going to get it for this.
I'll forgive you someday, Terry, but in the meantime, and listening to Lisa's story in particular, but Eric's as well, my reaction was filtered through my own experience, which is continuing one these days with a close family member who is has moderately advanced dementia, and managing the care for her, and in a sense, the almost on a day-to-day basis, total irrelevance of her very good physicians to the management of her day-to-day needs, combined with a total disconnection in a big city between her very good physicians, who are both specialists monitoring particular aspects of her health, and EMS and hospital emergency departments. And the centrality, Eric said, of 911 as a problem, as a weakness in, at least as it's now constituted in our care for people with dementia. The only other thing I could say I thought of in thinking of this was about 10 years ago, when a very excited entrepreneur came to see me about his great invention, because his mother had fallen in the tub and she had taken off her medical alert monitor because it wasn't waterproof, and he had gone out and paid some engineer a significant amount of money to design a waterproof medical alert thing, so if you could wear it in the tub. And I said, so what happens if she falls or passes out or whatever. And she said, well, it'll automatically call 911. And I said, that is the last thing you want to happen, because if 911 comes, they're going to take her to an emergency department. And by the time she gets out of there, she'll be in much worse shape. I mean, this is one thing we know, right, about geriatric care is emergency departments are to be avoided at all costs unless there really is no alternative. And the tendency in from all kinds of caregivers, when they don't know what to do, to call 911 is, you can't tell people never call 911 or whatever, but there is more harm done to frail old people with or without Alzheimer's by shipping them to emergency departments than, and when you think about quality measures, Eric, maybe this is a place to focus.
Thank you so much, Bruce, and a conversation to be continued. And welcome, Faith, and introduce yourself.
Thanks, Terry. Faith Mitchell, member of the Planning Committee and a fellow at the Urban Institute, and also the daughter of someone who had Alzheimer's disease, so bringing that experience as well. So I'm an anthropologist who's worked in health for years, so I'm always bringing that sort of population frame to questions that we talk about, as Terry knows, because I've been raising this repeatedly. So when you look demographically at the fact that, as the first speaker talked about, Alzheimer's disease is disproportionately high rates in Black populations, I keep framing everything people talk about in that because of what we know about people's problems with access and trust, and if they're Latino, but maybe language issues. And I'm frustrated because the recommendations don't seem to bring that nuance to them. So I keep thinking, how would this translate given who we know? I mean, if people are not listening to Eric, how are they going to be listening to somebody from Southeast or somebody where English is a second language? And so I guess I would just urge in the next generation of research that we start to try to ground some of our findings and recommendations, as I think Betty was referencing, in the realities of the people who are actually experiencing these conditions.
Thank you so much, Faith. And was there a response from NIA at all about that? And thinking about, not to catch you off guard, Teresa, but thinking about what programs of research, and you talked about making them pragmatic so that we can really get to the heart of what's going on the ground, as people have said. I'd like to have the panelists talk to one another. And I wonder, Betty, if you could start by just, what would you ask Eric? You heard him talk about NCQA. What would you two talk about?
One of the things I'm really proud about in our report is that in every chapter of our report, we addressed issues of diversity. And we had, many of our panelists that were there bringing, particular expertise, of which, of course, we all should be committed to issues of diversity and great inequity in nursing home care. And so I think it has to be interwoven in every aspect of care. And so, for example, the first chapter of our report that presents that model and talks about, what is quality care, and that it has to be based on, each individual, because what my mother needs may be different than your mother, and what your mother's values, may be different and may be very culturally bound. And so, for example, in one of our African-American members of our committee, really talked about when it comes to value-based care, that, it begins with that, entering, the room or, the care of an African-American woman, from her family perspective, that the nursing assistant should never refer to her mother by first name, that, that a sign of respect would be to always, refer to her as Mrs. Whatever. And so I think, then that ties together with staff training. And so, in my work, which has been primarily palliative care, and so my interest is end-of-life care in nursing homes and in all settings of care, one of the mantras that we always have is people can't practice what they don't know. Right? People cannot practice what they don't know. And so if we want EMT, clinicians or emergency rooms or nursing assistants in nursing homes to provide respectful care, to provide culturally, relevant care, to manage symptoms, to, provide comfort, that they have to be taught. And so a strong element of our report is we have to do a better job of staff training, because staff are not well prepared for all of the things that we've talked about today. And so one of our strong recommendations is that nursing homes must be held accountable to the training of staff if we're going to change the outcomes, change the stories. The stories of families won't change until we adopt the recommendations of our report.
Thank you, Betty. They have to change is right. And so we always say, what are we going to do tomorrow because of what we know today? And we'll be calling HRSA and talking to our friend Joan Weiss, who's doing a great job partnering with us. Eric, did you want to ask either of the panelists anything yourself?
Yeah, and I was reflecting on Faith's comments. The NCQA actually does have a health equity accreditation program that's really just launching. It's a revamp of a program that has existed for 10 years. And I think part of the equity standards and accreditation is meant to drive the sorts of changes from the health plan level that could be achieved. From a measurement standpoint, I think getting to the issues of trust and trust in particular, because of the historical legacy in many communities, and the degree to which people feel that they're treated unequally in whatever setting they're part of. I also think there's a chance to link, in our terms of our quality measurement strategies, bring community into the development of measures in a way that we haven't done before. There are some examples. Westside United in Chicago is probably one of the best I've seen, where the community participated in identifying the key indicators, working with, I think, 7 hospitals actually in that community that were providing care, and just creating that joint accountability. Community and hospital leadership, I think, has been powerful. I've not seen it in that attempted. Maybe it's there and I'm not aware of it. The third thing I just wanted to, and I'd be curious to hear the other speakers' thoughts on the staffing. We've been talking about training. I just got a call that about 30 or 40 staff are out on COVID test results at my stepmother's facility. And they were already understaffed. I actually can't even imagine how they're handling all of the things that they're charged with taking care of right now. So I wonder, I'd be curious to hear what the thinking is around bolstering the availability of staff that are, we're just woefully understaffed, I think, in these settings.
Betty, you want to comment?
With that regard, that the 7 key areas of recommendations of our report, we try to really emphasize they're very interrelated. You can't just pick one and say, okay, we'll do this. We'll act on this recommendation and ignore the others, because we have to act on all of those recommendations. And so, for example, why are 40 staff, contracting COVID? I mean, we know that rates are high. That these are very vulnerable people. We know that over 2,000 staff in nursing homes have died from COVID themselves. So we know these are very, very real issues, but, we have to look at the collective. We have to look at, why such high rates and the safety issues that pertain to staff. We have to, again, this is beyond just the issue of staff out, for COVID, but we have to look at safety, precautions within nursing homes, and we have to look at the issue of just payment. And so, attracting and retaining qualified staff in nursing homes begins with, are we paying appropriate wages? And that was a huge factor, in our report. And we've all heard across many, many studies that when you have over 100% turnover in a nursing home, how can you possibly think that the person who's taking care, of your loved one today even knows who they are, much less, their preferences, their values, what means quality care to them. So until we deal with basic issues of paying for staff, retaining them, training them, we won't see the impact on resident care.
Lisa, stand by. I have a question for you in just a moment, but I want to ask the audience here and broadly, can you imagine a time when the hospital would send staff over to the nursing home? How hard is that? What's wrong with us that we can't deploy resources and services across our care setting? And I practice nursing. I most recently was practicing nursing last week, and I saw new staff, and I said, "Hi, where were you before? Nursing home?" Really? The third time I heard that, I worried, because that means that in our very own community, the city, we're cannibalizing one another's staff. And so we have to ask ourselves, can you imagine a time when we do things differently? That might be useful. And the reason we don't is rampant ageism. We like our siloed approach because then we don't have to see older people with dementia, because they're hard and they make us sad and they're hard to take care of. It's very hard to take care of a pressure wound on an older individual if they are vocalizing very loudly and you think you're putting them in pain. So until we're all in the same room at the same time, what if you closed every nursing home in the country and let Mass General back up for a while, That would be okay. We're going to have to test different models, and I'm looking at Peter and hoping that he'll join in the conversation as well, as somebody who's so astute in all the areas of long-term care. So I'd like us to imagine rules that could be broken, and let me turn it to anybody online. Do we have anybody online yet, Crystal? Okay. Then waiting for them, is there anybody in this room who'd like to comment? Peter, do you want to join us and introduce yourself?
Named unknown commenter. Yeah, I mean, we have, I'm Peter Holman, Brown University, and also work with an ACO in Providence, Rhode Island. I have, as a geriatrician, I have spent time in pretty much all settings of care. And as a primary care physician, I, probably not unlike Dr. Schneider, came through an era where you saw patients in the office, you knew them very well. I'm not a family physician, but I ended up treating the children of my first patients who are now in their 90s themselves. And so you know a lot about people, and you would see them in the hospital, you would go to the nursing home. We have definitely fragmented our system so that it's very rare that a care team can go across settings effectively. If you get transferred a couple times to different nursing homes, you don't exist as a person. Your possessions have probably been lost. Your identity's been lost. Nobody really knows you unless you have someone like Lisa Gwyther caring for you and standing by your side all the time. It's a real challenge, but I do think if we recognize the importance of long-term care, we give opportunity to people to come to the country and work in the area, because let's be candid, it is something that is definitely going to be immigration related. If we give those people opportunities to learn more about their field, treat them as the professionals they are, maybe they don't have those long educations and long degrees, I think we'll do well. And I don't really know what to say about the nursing shortage in general. You're a nurse. I think that is one of the single biggest crises facing our country. We have to figure out a way that nursing, and I get nervous when I talk to you, Terry, because you're such an expert on things, but we need to find a way that we can educate nurses that is a little less reliant upon the doctoral level, et cetera, nursing educators that we would love to have, but if they aren't there, we're just going to not be turning out the population that we have to do. So I think there's probably lots of things, probably immigration and nursing education would be a couple of things that would dramatically improve the situation.
Thank you, Peter. And I don't disagree with you at all. You know, whenever there's a nursing shortage, all of a sudden we remember there's such a thing as LPN schools. Imagine that. So, Lisa, You were president of the Gerontological Society of America. Talk to us about ageism.
Ageism. I think that people think of older people as less interesting, less complicated than they really are, and less diverse than they really are. And I think ageism, people tend to lump those things together. And that's really difficult. I think people become more unlike than like as they age, and that getting to know an individual in his context or her context becomes really important. And I don't think we have done that. Our language doesn't do that. Our frameworks don't do that. GSA has worked very hard on trying to reframe aging in a way that's less stigmatizing, less discriminatory, and also recognizes the diversity of the aging experience.
I so appreciate that, Lisa. And reflecting on what you heard from Betty and from Eric, any other comments you want to make before we go to the online audience?
I just want to thank Eric. In our original conversations, he decided to use some of his own experience. I think it was very instructive. And I think that even though we are in privileged, knowledgeable positions, we pointed out what we couldn't do. And I also think that we learned a lot from what did work and what worked well in our individual situations. And that comprehensive, consistent team of people who can follow someone over time and who becomes an expert in that individual, while it's unrealistic, is ideal and makes a real difference in the quality of care.
Thank you very much, Lisa. Why don't we go to our people in our online audience?
This came from Elizabeth Belmont, and she asks, what are your thoughts on the best financial model to promote appropriate care for Alzheimer's patients, and what actions would facilitate the adoption of such models by CMS and other payers?
Thank you. And I'm looking, I know that we're going to have a detailed conversation about more about payment coming up. At 12:55, it says transforming the role of payment. But having said that, do you want to comment, Eric?
Yeah, I'll just comment that we are in the process, the healthcare system's in the process of a transition from a fee-for-service based approach to paying for care to what people are colloquially calling value-based contracting. What that actually means is, maybe we'll hear more on the next panel, but I do think that's one of the reasons it's so important that we get the quality measurement system right, because to truly reward value means being able to measure quality and measure it accurately and reward it as it occurs, or make grants to create the infrastructure. I think we sometimes overestimate what can be done with incentives. Repeating a point I made earlier, and we have to think about what direct sorts of payments we might need to accomplish some of the goals, the ambitious goals that are laid out to improve care for people with dementia.
Thank you so much. Other online, Crystal, thank you.
This comes from Sarah Locke from AARP. She says, I agree, Terry, it's rampant ageism and fatalism, but instilling that there are fixable issues that will help are very important to instill amongst younger healthcare providers. How can we always ask the older person what outcomes matter most to them when they work from there? So more comment than a question.
Thank you, Sarah, and for your amazing work on the Global Brain Health Initiative at AARP, where we learn so much from you every day, and your commitment to this area. So you guys are inviting me in to give you a speech on age-friendly health systems, and I won't do it. But Faith can help me because she's on our advisory board and does a great job. But we need to have a shared framework and a common language across our care settings, and one that can be used by consumers. So that's why we work with the Institute for Healthcare Improvement every single day, where they have taught us how to really do implementation science and how to measure it and watch our quality grow and watch the triple aim: better care, lower cost, better value. So what matters? There are 4 M's. What matters? Mentation, medication, mobility. You heard it in Eric's story. You heard it in Faith's story. You hear it in Lisa's story. So we have had 30 years plus of falls reduction programs where people then develop sarcopenia because they are kept in bed. So changing the structure and the way that we think about that, and I recommend you to the IHI website. They are the heroes of this work. To say that if we could just, we have a book on that. We have a new nursing home set coming out that talks about the 4 M's in nursing home care. We have to be able to have the nursing assistant use the same words that we use, the same words the surgeon uses, so that we begin to get some consistency of structure. These are all evidence-based. IHI has done a phenomenal job, and grateful to Don Berwick for his leadership, along with John Perlin and Faith as our chief advisors. So I feel strongly that until you do that, we will continue to have fragmentation. Yeah.
Another question from online, Julie Robison from UConn Center on Aging and another member of our planning committee. 911 responses typically don't get reimbursed unless they transport a patient to a hospital. Could Terry's suggestion of bringing the hospital to the nursing home or home be implemented by training and paying EMS providers to provide care on site?
Yeah, I think there are some models that people are experimenting with on that front. Unfortunately, they're not coming to mind right now. Maybe someone else in the audience knows what those are. I did want to comment, I was reflecting on Lisa's story, that, and Bruce mentioned this too, that caregivers actually are innovating all the time. And we actually, I don't feel like we tap that innovation potential. I was reminded by Bruce's story about the medic alert system. An engineer whose parent was in a challenging situation actually spent it's probably less than $18, and put together a sensing system that she could put in the bathroom that wasn't an image, but it was a motion detector that would tell the family if either the person wasn't moving or fell or something. And so there's a whole, of course, I was also tying this, Terry, to what you described about ageism and about the loss. We don't gain the creativity that could be there from caregivers while billions are flowing into Silicon Valley for all sorts of zany ideas. So I wonder if there's an agenda there around bringing forward caregiver innovations and engaging caregivers in redesigning our systems.
Some of you might be aware of the innovation in Japan, where they have an inverted curve of younger people to older people, pyramid, and they use a lot more robotics. That it would be impossible for them to have human beings carry linens around and carry trays around. They have to innovate, and they have robots who are receptionists in hotels and very soon in hospitals, who don't make as many mistakes as people do. So looking around the world, and WHO just released a very interesting report on long-term services and supports that I recommend to any of you. And here comes Lori. Hi, Lori.
This one came from Barbara Matthews, and she said, with personal experiences, being an expert in the field is certainly an advantage. I wonder, conversely, if there are challenges specific to having expertise.
We'll start with Lisa, then we'll go to Eric and Betty. You have any challenges being an expert, Lisa?
Constantly. But I think that being an expert means that you know what is real in what you can expect. And so I think I have learned through personal experience that you have to modify your knowledge of what's perfect for what's good enough for now. But you have to, the one thing that I have learned from professional experience is that there's no substitute for somebody who knows somebody well. And so it's really important, if you have that available person, that you use their expertise. I would also say that what I've learned since becoming a wife caregiver is that nurses and direct care CNAs have developed, the ones who are consistent and have been there a while, have developed really great tricks. And I've learned as much from them as they've learned from me about my husband's care. And I think that ability to trade off between the direct care provider's experience and the family's experience is crucial.
Go ahead, Eric.
Yeah, I'm often reminded of William Osler's comment that the doctor who tries to treat himself has a fool for a doctor and an idiot for a patient. I'm incredibly humbled, actually, by going into settings where people do this work. And I recognize, I try really hard when I'm not tearing my hair out to recognize my own limitations and my own biases and my own inability maybe to understand the culture that people are working in. And so I've approached, I've also been really mindful that I can make things go worse if I approach it with the wrong attitude, with sort of I know better or I know best, or it's a very delicate balance, though, to try to make sure that I'm advocating for the person that I'm, with, and but also recognizing the challenging circumstances that people are working under, and trying to thread that needle is a constant battle. I think, Lisa, you expressed it well.
Yes. Betty, did you want to add anything?
No, I would just say when our report was released, I was talking to a journalist, and after we had completed our interview, this really outstanding journalist who has such an ability to communicate with the public said to me, he said, can I ask you something, kind of off the record? He said, I'm really committed to this and helping to spread the word, but I need you to tell me, is it hopeless? And because, I just feel sometimes that this is hopeless. And so if it's really hopeless, I can't keep spending my, time. And so I said, absolutely, it is so doable, everything we've asked for. The fact that we would know someone's preferences, the fact that we would treat them with respect, the fact that, we could do all the things you've heard about today is so achievable. And so I think as a healthcare provider, I also come to this conversation with constantly being aware that, we are not asking for the impossible. Everything we've talked about today is so doable. And Terry, I was thinking, sort of thinking big and thinking, how could we really make change? We have technology now. To create a training program, we've all heard what we wish the nursing assistant knew about, how to bathe or care or feed or talk to the people we care about. We know the knowledge, we know the content. It would be possible to create a training program to train every staff member that works in every facility in this country, and to make that available to every facility in this country free, right? Free. Create it and get it out there. And then, combine that with structures and processes. So, our report says we are calling, for mandatory education of the staff. We are calling for the fact that every facility needs a social worker. So when will facilities begin to know the values and respect the person you love? Well, when there's a social worker present who is paused to say, who are you? What matters to you? and then we have a written plan of care for that person. So I think we need to combine the goodwill, what we know would be good, with practical use of things like technology that bring that technology into nursing homes that exist everywhere else in hotels and businesses. Bring that technology in, and so combine. We do need structures, regulation, finances. We need to change the way that care is paid for and delivered. But if you bring that together with very practical solutions, it absolutely can be done. But I do think a huge part is we need a widespread, media and public campaign that says it is possible for the people you love to have outstanding care by qualified people in a safe environment. That is possible, and you should expect it. That should be the message.
I think that's a great message, and I'd like to just call out two other groups that are a part of this whole discussion and solution. Lori Porter, who served with me on the White House Commission on quality care in nursing homes 2 summers ago, is the head of the National Center for Nursing Assistance, the national organization that does have incredible training programs, and I'm watching that work, Lori Porter and that organization. Then to talk about National Guard. The National Guard, I'm from a very small town upstate New York, and if something happens to staff, the National Guard come. And they do an excellent job, by the way, but it's a little unnerving to see the National Guard in your facility. Having said that, let's think about the other frontline people who are helping us in this discussion. In the Adirondacks, your first responder will be a fireman, most likely, or maybe a policeman, but usually the fire people come first. And then you get in an ambulance and you go an hour and 10 plus minutes to get to Utica, New York. So we're in that section. So reminding us that there's an additional set of people who can help be made aware of appropriate responses to people with Alzheimer's. We are talking about people with Alzheimer's disease today, and we're talking about community. And in most of the communities where those towns are that I just alluded to, there's about 400, 500 people per community, and I guarantee you that the firefighters know where everybody is who's got a memory problem. So working smart, thinking about the ways to knit this together, do your science in order to prove the evidence that using community-based solutions, working with all the people who are available to you. We're also having conversations with YMCAs. Now, the YMCAs could be wonderful if they began to do adult day programs, and some of them have. Libraries, what can libraries do to help us in all of this with people who are in the first stages or the first and second stage with either preclinical, as David said, or mild. So these mega infrastructures in our country that I'd like to knit together. So other comments? Go ahead, Lori.
It's a comment from Sharon Inouye, and she says, Dr. Ferrell relates the sense of hopelessness felt by the reporter. I believe the fear, hopelessness, sense of inevitability lies behind much of the inertia in creating change in this area. Yes, it's complex. Yes, it's difficult. But there are so many potential solutions and changes that can help. We need to think about how to combat that inertia.
I love that, Sharon, and we're glad you're a speaker today with us and look forward to you elaborating on that. We have about 2 minutes and before we go to break, and I wanted to just have a closing comment from each of our speakers. And why don't I start with Lisa? Lisa?
I guess my closing comment is that there's a lot of good care going on, and we can use that in our training, in the way we approach the redesign of financing and care. And if we look at that, there may be ways to scale up good care in these small settings. Thank you.
Thank you for joining us, Lisa, as always. And Eric?
Thanks. I'm thinking about the patient safety movement and the whole the construct of team-based care, and it comes up in the patient-centered medical home as well. And I think we often think of the team as sort of the team of professionals, but to your comment about the community, to the earlier discussion about caregivers, I think fostering the sort of team-based model involving all of those folks and creating the sorts of training and protocols for how they should interact could overcome some of, I think, what happens as the adversarial element between different sectors as they try to navigate the care of people who have really difficult challenges.
Well said. Betty, why don't you have the final word today?
Ultimately, one of the things we talked about in our committee a lot is at the end of the day, this is a moral issue because it's wrong. It's just wrong for a society to ignore elderly people, residents of nursing homes, those with dementia. It's wrong. And so we have to start with a basic commitment that at our country, it should be shameful that we even have to have this conversation. When our committee was doing our report and we were looking for models, we ended up talking with a lot of colleagues internationally. And the consistent response as we would talk to many countries who are doing this quite well is they were shocked. They were like literally shocked. Like, what do you mean that America can't provide, a high quality of care to residents in nursing homes? Like, how can this be possible? Like, they honestly did not believe our data. And so I think that is really, what should happen. What should happen is that as a society, we should be shocked if we hear of a resident not getting quality care, right? We should be shocked if we hear the stories that we've heard today, because they should be so rare. And so, but it has to start with a real public awareness that what happens today is immoral. It is wrong.
Thank you, Betty. And would everybody please join me in a round of applause, virtually or in person, for our panel? Thank you so much. And we're going to go on break. It says here 11:55 to 12:55, and then we'll be back at that time. Thank you so much.